Today I'm going to be talking about the diagnosis and management of traumatic anterior shoulder instability. This was a topic that had a recent JAAOS review last year, and it has evolved over the past 10 or so years in terms of how we address this. It's a common scenario we see in clinic, and there's a bit to talk about. So I'll try and gear this towards the junior registrars and residents and go from there. To understand the shoulder and instability, we need to understand the stabilisers, and we divide these into static and dynamic stabilisers. The static stabilisers are particularly important at end range of motion, and these can be further divided into bony and soft tissue. And the glenoid anatomy and the version is part of the static stability. However, as we know, the shoulder is a relatively unconstrained joint, highly mobile, and thereby we depend a lot more on the soft tissues. The anterior band of the inferior glenohumeral ligament is the most important ligament for anterior shoulder stability. And this comes into play particularly in abduction at 90 degrees and 90 degrees of ER. The middle glenohumeral ligament is at 45 degrees abduction and external rotation, and the superior glenohumeral ligament is with the arm by your side. The labrum further adds stability, increases the glenoid depth by 50%, and is particularly important because it helps form the seal within the shoulder that creates a negative pressure vacuum seal effect. Dynamic stabilizers are the rotator cuff and the long head of biceps. And it's particularly important with the force couple between the anterior cuff musculature and the posterior cuff musculature. Considerations when we're talking about instability, why do we do the things we do, revolves around these three main issues, and that's cuff tear, redislocation, and progression of arthritis. What we know is that in a patient age greater than 60, there is an 80% concomitant cuff tear rate, and this is about 40% in the 40 to 60-year-old group. Beneath this are concerns less about cuff tear and more about recurrent instability. Recurrent instability has a 90% risk of recurrence if you're less than 20 at the time of your first dislocation. And if you're between 20 and 40, that figure's about 60%. If you're over 40, then again, your problem's most likely to be a cuff tear rather than recurrent instability. There's some studies that shown that progression of arthritis from a single dislocator, you can predict that 20% will go on to have osteoarthritis, but 40% will go on if you're a recurrent dislocator. So you double the risk. And this is important, particularly in certain presentations we'll talk about later. I'll go over history and examination briefly. This is by no means comprehensive, but it can be fairly dull going through all the examination through written text. I encourage you to go to clinic and see the shoulder surgeons show you how to do a lot of these tests. The chief complaint that instability patients have is instability itself, a shoulder dislocating, but it can also be activity-related pain, particularly with overhead activities, with smaller subluxation episodes. You really want to ascertain if the patient's got a history of generalized ligamentous laxity, such as Ehlers-Danlos syndrome, and previous instability events are important in terms of quantifying and the magnitude of the dislocations as well. Mechanisms also important, as higher energy mechanisms are more likely to result in repeated dislocations. Function, activity level, and what limitations the patient has is very important. And in particular, in terms of your treatment, you want to know what the patient's expectations for their treatment are and what their intentions are in terms of returning to activities, particularly contact sports. On examination, inspection, it's the usual stuff, look, feel, move, special tests, and neurological examinations are especially important. Symmetry and wasting or subluxation can often be evident, and you want to look for wasting, particularly around the periscapular musculature. And you want to feel palpation for tenderness. Move, you want to do an active screen first, and special tests largely revolve around the apprehension tests, the relocation tests, load and shift, and sulcus signs, which you'd look for in generalized ligamentous laxity. Baton score is the score that you'd talk about for ligamentous laxity. We won't go over that today. Neurological examination, particularly in older patients, brachial plexus exam is important in shoulder dislocations, and in some cases, axillary artery can be involved. The figure on the right there shows the proximity of these structures to where the shoulder is. And it's worth keeping in mind, particularly the axillary nerve and the axillary artery. The axillary nerve is usually a transient neuropraxia, and this is often present in 5% of shoulder dislocations. In terms of workup, there's X-rays, MRI, and CT. And X-rays, although often skipped when you see them in the outpatient setting, I think are quite important. Not only does perusing the old X-rays show what direction the instability was in and confirming whether it was a full-blown dislocation, but it also tells you what the state of the joint is, whether they already have some arthritis or some superior humeral escape. You can also often see a bony Bankart and any GTLT fractures or a Hill-Sachs. MRI is the main go-to that people use in the outpatient setting to look for a Bankart lesion, and there's various other lesions I'll talk about, including a GLAD, ALPSA, Perthes, and a Hagel. CT is really looking for glenoid bone loss, as it gives us better bony anatomy than an MRI, and it also gives us a bit more information about our Hill-Sachs and can help us decide whether it's an on-track or off-track decision. Bankart lesions. So this is present in 80 to 90% of patients with traumatic anterior shoulder dislocation, and avulsion of the anterior labrum is the pathoanatomy of that. This includes the inferior glenohumeral ligament from the anterior inferior glenoid. And as we mentioned earlier, this is important because the labrum seals the interface between the glenoid and the humeral head, and it creates that negative intra-articular pressure. On the right, there are some figures which will come up for all of these lesions, which help to really explain what we're talking about here, with the top one being the common soft tissue Bankart, and then the bottom one showing a bony Bankart as well. Perthes lesions are a variation of a Bankart lesion and is a precursor to an ALPSA, which I'll talk about next. Basically, it's a Bankart with an intact scapular periosteum that's avulsed but not torn. A Perthes lesion that heals onto the medial glenoid neck is an ALPSA. And that's important when you look at an ALPSA next, because what can happen with an ALPSA is the periosteum heals down to the front of the glenoid. And if you fail to recognize this and you don't mobilize this appropriately, you're not going to get the anterior bumper and recreation of the capsular plication that you're after. So these have a higher failure rate with arthroscopic repair, particularly if that anterior periosteum's not mobilized in a sleeve-like fashion off the front. So it's just something to notice on your MRI scan. GLAD is a glenoid labral articular disruption, and it's a tear of the anterior-inferior labrum with an associated injury of the glenoid cartilage. And often these patients complain of anterior shoulder pain, and this is a bad sign for ongoing bone loss and residual instability, particularly if this isn't addressed. And then there's the Hagel. So the Hagel is a humeral avulsion of the glenohumeral ligament. It's the inferior glenohumeral ligament. And this is often a hyperabduction and ER injury, and it's usually from a traction mechanism rather than a direct collision. Pain is often their primary issue, and 9% of traumatic anterior dislocations have this. It results in incompetence of the inferior glenohumeral ligament and that axillary pouching that's characteristic on the MRI. Again, this is important to recognize because failing to address this will lead to higher recurrence rates from your operative outcomes. Usually, this would be addressed with open techniques. The figure at the bottom shows normal pouch, and the Hagel shows the clearly disrupted axillary pouch there. It comes off the humeral side. So this is just a nice little diagram explaining all those things, just for the juniors to refer to if you're wondering what it all means. Reverse Bankart's the same as a Bankart, but you'll see it in the posterior dislocation. And it's important to notice that, as some of these patients will have anterior and posterior instability, and you need to address this at the time of your surgery. Shoulder instability is a complex interplay between glenoid and humeral side lesions, soft tissue considerations, and patient requirements. And really the challenge we have as surgeons is to predict who needs what procedure. And there have been several studies that have shown that even seemingly insignificant bone loss, less than 10%, may actually benefit from a bony procedure, particularly if it's bipolar on the humeral and glenoid side. So we need to talk a bit about glenoid bone loss, and this is where it gets interesting in my opinion. There's glenoid fractures present in 1/3 of first-time anterior shoulder dislocations. And we talk about this concept of critical glenoid bone loss. This figure is controversial. We used to say 25% or more will always need a bony procedure. However, recent literature has shown that in young active adults, even 13.5% is significant. And that can be quite subtle. Unless you look at glenoids a lot, it can be difficult to pick up. The best way to measure it's this best fit circle, as demonstrated here. You draw a circle at the inferior end of the pair, and in that inferior 2/3, and you can measure that diameter at its widest point. The glenoid index is another way you can do it, which is the maximum diameter of the inferior 2/3 compared to the contralateral uninjured glenoid, if you happen to have the scans from the other side. Glenoid track is the contact area between the humeral head and glenoid as the arm goes into abduction and external rotation. And this is important because the Hill-Sachs lesion, which is the posterior depression on the back of the humerus as it impacts on the anterior glenoid, is present in 90% of patients. We used to talk about the Hill-Sachs as engaging or non-engaging, and often this was assessed intraoperatively. However, now the preference would be to try and preoperatively estimate whether or not this will be an on-track or off-track lesion and whether it needs to be addressed ahead of time. And Yamamoto described a method to judge this preoperatively. When you first see this formula and try and figure this out, especially for the juniors, it can be a bit confusing to remember and to understand. But basically what you're doing is they figured out that you can measure the width of the glenoid, and that's big D. If you then multiply that by 0.83, that will then give you an estimate of the contact track on the humeral head. As you lose glenoid bone stock anteriorly, which they use little d to represent, that will then allow that humerus to engage earlier with the anterior glenoid. So what you do is you measure the 83% of the normal glenoid as you would have estimated it, and then you minus the little d from that measurement, and that's going to give you a glenoid track. The Hill-Sachs index you see on the humeral view is the width of the Hill-Sachs, and then you also add the bone bridge between the lateral margin of the Hill-Sachs and the rotator cuff attachment. So in this figure, that's the red line that you can see once they've been added together. The significance of this is that if your Hill-Sachs index is more than your glenoid track, then the glenoid track is off track and will engage. So it's not just about the width of your Hill-Sachs, it's also how far medially this comes across on your humeral head from the rotator insertion. And another way to think about this is the analogy of a car on some tracks, the car being your glenoid and the tracks being your Hill-Sachs defect. If you have a nice big glenoid or a large four-wheel drive, even if your Hill-Sachs is fairly large, you can stay out of that divot. However, if the Hill-Sachs gets too medial or too large, you can still fall in it. And if you have a tiny little car, which is a glenoid with significant anterior bony loss, you're going to come off track more readily. And this would suggest you either need to do a bony procedure or a Remplissage type procedure into your Hill-Sachs. This is just another diagram explaining that concept. The key take home from all this is that addressing glenoid bone loss widens the glenoid track to such an extent that the Hill-Sachs lesions cannot go off track. And if you understand that, you'll understand the algorithm for deciding what you want to do. In terms of overview of management, we need to talk about first-time dislocators versus recurrent dislocators. We need to understand the associated injuries, whether your issue is a cuff tear or a bony fracture that needs addressing. And you want to know the patient in terms of athletes, high-demand activities. And age is a big factor in your decision-making. As always, beware of the habitual dislocator and multi-directional instability. So first-time dislocators, what should we do? There's a little bit of controversy in this area. However, I think there's more and more literature consensus that if you're less than 22 years old, you should be thinking about doing an early stabilization. Contact athletes as well. This is very United States driven, but a lot of contact athletes, the decision as to when to operate often is done in the off season with a view to return the next season. But contact athletes have a really high risk of redislocation and should probably have something done if they want to continue in that sport. Bony Bankarts as well are a relative indication to do something early, even if small, because repeated anterior instability can lead to more glenoid bone loss. And we know that these fragments resorb if they're not addressed. So incorporating them into a capsular-labral repair if they're small does work well. Risk factors for redislocation, so an age less than 20, male, contact sports, hyperlaxity and glenoid bone loss are all things you should consider in the first-time dislocator. For a lot of patients, our management is going to be non-operative, and there was some contention as to how we should be bracing these patients. Initially, particularly out of Japan, an ER brace showed promising results, the idea being that holding the humerus in ER better reduces the anterior labrum and allows it to heal in a better spot. However, this hasn't been replicated in other studies, and most institutions will continue to just use a broad arm sling for comfort, and we know there's no benefit to immobilizing for more than 1 week. Physical therapy for strengthening dynamic stabilizers is key, and that involves rotator cuff and periscapular musculature. Operative management, these are the main workhorses we'll be talking about that we'll most commonly see, and that's an arthroscopic Bankart repair with certain adjuncts in certain situations, such as an inferior capsular shift or a remplissage, or a Latarjet, which has gained a lot of traction in recent years, and some surgeons will regularly do as a routine primary procedure in some of their patients. So how do we decide between a Bankart and the need to do a Latarjet? Well, apart from on-track, off-track discussions that we'll go into a little bit more, there's been several scores that have been proposed. The unfortunately named ISIS score, which is the Injury Severity Index score, is the one people most commonly quote. And this is based on largely the age of surgery and the degree of sports, such as competitive sports, and the presence of a Hill-Sachs lesion or glenoid bone loss on x-rays. If you think about this logically in clinic, you often don't need to calculate the score. The things to be aware of is if your patient's less than 20 and they want to go back to contact sports and they have a Hill-Sachs, there's a lot of things pointing towards needing to do a Hill-Sachs, a Latarjet, sorry. The table on the right indicates how they figured this out, and they worked out that a score of 6 or higher, you have a 70% chance of a Bankart repair recurring, a failure of your repair, sorry. So therefore, a Bristow Latarjet procedure would be a better choice. If you're between 3 to 6, then that goes down to 10%. However, the validity of the ISIS has been questioned, and a lot of surgeons feel that it overcalls the need to do Latarjets. And Diacon et al. Compared ISIS with their own instability score, which is called the GTIMS, Glenoid Tract Instability Management Score. It's a very similar score to ISIS, but they changed the X-ray features to a 3D CT scan, and they use the on-track, off-track classification. And they found that it more accurately predicts failure after arthroscopic Bankart repair and reduced the number of Latarjet procedures with no difference to outcomes. So that's the GTIM score, and that's, again, probably something I'd use. The key there is, again, if it's off-track and the patient wants to go back to contact sports that are competitive, then you're starting to think that you need something a bit more robust than the Bankart. So if you're in the exam and your mind goes blank and you don't want to overcomplicate things, this is the simple operative algorithm that stands true. And that's that if you got glenoid bone loss of more than 25%, you must treat this with a bone graft as it widens the glenoid tract so the Hill-Sachs lesion cannot go off track, as we discussed earlier. If you got less than 25% glenoid bone loss, but then it's an off-track lesion, the Hill-Sachs index is greater than 83% of the glenoid diameter, then you should consider adding in a remplissage when doing a soft tissue stabilization. The JAAOS review brings in the concept of less glenoid bone loss actually being more important than we used to think, and this is their algorithm for that, with this range of 13.5%, where you can start talking about whether you're doing remplissages or an inferior capsular shift. So Bankart repair, I'm not going to spend too much time on the operative nitty-gritty details. There's a lot of operative techniques, but the key take-home message is that arthroscopic management is equally efficacious as open repair with less pain and greater motion preservation. The recurrence rate varies wildly in the literature, but typically with modern techniques, we'd be quoting 5 to 10% as a recurrence rate for a Bankart repair dislocation. Portals, you want to establish your standard posterior viewing portal, and the key really to this operation is having a good anterior portal that's low in the skin and low, just skimming the subscapularis muscle anteriorly. And this is to allow you to get to that low 5:30, 6 o'clock position on the glenoid face. In terms of your preparation, you want to recognize any posterior pathology and address that as needed, but the key to the operation is to use the liberator to mobilize the labrum capsule and rasp the bony surfaces and really do that inferior plication and capsular shift with your stitches. Your first is going to be at a 5:30 position on the face. You want to put them in about 45 degrees to the articular surface. And a lot of surgeons I've seen will often use a knotted anchor inferiorly, as you can have your drill sleeve in, which helps you lever the head out of the way, and you can leave it in when you're putting your anchor. It just helps you get access. Subsequent anchors up the anterior glenoid face, a lot of surgeons will go knotless due to convenience. Which brings us to the Latarjet. This is the coracoid transfer with attached conjoined tendon and CA ligament. And we believe this has a triple effect. Basically, we talk about a sling effect of a conjoined tendon and the inferior 1/3 of subscap as it remains as an anterior restraint and it no longer glides superiorly in abduction. Basically, the conjoined tendon, you split through subscap and repair. As you go into ER and abduction, that subscap buttresses up against the conjoined tendon and slings it around inferiorly. It's a little bit hard to explain in terms of in terms of talking about it, but if I can find one of you guys afterwards, I can show you a good little video on it. Restoration of attritional glenoid surface is the easiest way to think about it. You're just putting a bony block out the front and increasing the glenoid track. And repair of the anterior capsule to a stump of the coracoacromial ligament is another bumper to this, not dislocating out the front anymore. Instability recurrence is less than a Bankart repair. It's about 1 to 6%. And there were two methods originally described, the traditional method and the congruent arc method. This was described back in 1954, where Latarjet used to take the coracoid and put the undersurface right up against the glenoid deficit. However, the issue with this is that you have an incongruent surface, and this would lead to higher rates of arthritis. So Bankart and Anterior in 2000 developed the congruent arc technique, where you flip it 90 degrees along its long axis, and then you can put the undersurface of the coracoid, which is conveniently quite well shaped to fit the natural curvature of the glenoid. The general management of your subscapularis on approach, you can either do an L-shaped split in your subscap, preserving the inferior half, or with a bit more experience and knowledge of your exposure, some surgeons have moved to a subscap split between the upper 2/3 and lower third. You then do an L-shaped capsulotomy, and you take it 1 centimeter medial to the glenoid to preserve as much capsular length as possible for later reattachment. The graft should be 2 to 0.5 to 3 centimeters, and the osteotomy is done just anterior to your CC ligaments. And the key really is that you want to place this flush to avoid arthritis. The anterior capsule is then stitched in front of your graft to thereby make your graft extra articular, so you don't have cartilage rubbing on a non-articular surface. Problems with the Latarjet are numerous. There's graft resorption, which goes up to 60%, malposition, or you can fracture the graft as well. Non-unions reported up to 9%, and screw back out is a common issue as well. Loss of ER by about 15 to 20 degrees is what you'd expect, as subscap is shortened, and also your capsular repair. Injury of the musculocutaneous nerve and axillary nerve, or a vascular injury, is quoted in up to 10%. And there's a reported 20% rate of arthritis at 20 years. Revision Latarjet is a tricky topic, but just know your options. There's the Eden Hibernet, which is an iliac crest autograft, and fixing it in place. Richard Page proposes that you do an endo button suture bridge as you have limited bone stock. Other options, particularly the Americans talk about, is the distal tibial allograft, as it recreates the architecture of the glenoid with the benefit of a cartilage-covered graft surface. Very quickly, Remplissage is French to fill, and what you're doing there is trying to address your Hill-Sachs lesion, and this has been done successfully even with glenoid bone loss approaching that 25% mark. The disadvantage is that you reduce your ER, and really your goal is to convert the Hill-Sachs into a non-articulating lesion by tenodesis of the infraspinatus into the defect, and this can be done arthroscopically. There are other options, including bone grafting, hemicap, or in some cases, you can even do a rotational osteotomy of that humeral head to get the Hill-Sachs further away from where it's engaging. This is the final slide. So how I'll think about it, and my general approach, is you split it into 13.5% through to 25%. If you got less than 13.5% glenoid bone loss, then you're probably safe to do a Bankart repair, provided there's provided the Hill-Sachs lesion is on track. If you got more than 25%, then you're looking at a Latarjet. The grey areas, these ones in the middle, where if you got less than 13.5%, but an off-track Hill-Sachs lesion, then you should be thinking about a Remplissage, or some surgeons will go straight to a Latarjet for that scenario. And again, the GTIM score of greater than 6 can help you decide that based on your patient and their demands. Glenoid, if you have 13.5 to 25% and an on-track Hill-Sachs lesion, then you can get away with just a Bankart and a Remplissage. A glenoid of 13.5 to 25% and off-track, really there's a bit too much bony stuff going on there, and the recommendation would be to go to a Latarjet. And that's it. The JAAOS article is very helpful for this, and a variety of other sources there.